So the first study is the Ariel 3 study, which assessed the value of adding rucaparib to the treatment in patients with platinum-sensitive recurrent disease. The standard dose was 600 milligrams BID. Of note, many patients required dose reductions during this trial, and albeit dose reductions, the data are still statistically significant, highly significant, and clinically meaningful. The other study is the NOVA study, which compared niraparib to placebo in a 2-to-1 fashion in patients that had either partial or complete response and normalization of their CA-125. Likewise, over 60% of these patients had to dose reduce the initial dose of 300 milligram, which did not minimize the treatment effect, as retrospective studies had shown that those with 200 milligrams experienced the same benefit as those with 300 milligrams daily dose. And the last study are two studies. One is the study 19, which was a study that was conducted years ago and fully published, assessing the use of olaparib as a maintenance therapy, in fact as a capsule form, 400 milligrams BID, in patients that had a good response to preceding chemotherapy. And this is supplemented by the SOLO 2 study, which looked at the response of olaparib or the improvement in progression-free survival of olaparib using the capsule formulation, 300 milligrams, it's the tablet formulation, BID, in patients with a partial or complete response after platinum-based chemotherapy. And all studies showed identical, nearly 4- to 5-fold improvements in progression-free survival in those that have either a germline or a somatic mutation, and a more than doubling of progression-free survival in those that have a BRCA-like signature, and approximately a 3 to 4 months improvement in those that are exquisitely platinum sensitive, that are biomarker negative.